All right, so we're going to get started. I'd like to welcome you. Good afternoon, and welcome to the Center's first webinar for the 2013-2014 academic year. I'm Professor Jerry Kaminsky, and I serve as Director of the UCLA Center for Health Policy Research. And I'm pleased to introduce today's speaker, Professor Michael Goldstein. Dr. Goldstein is a Professor of Community Health Sciences and Sociology at UCLA, and currently serves as Associate Vice Provost in charge of the Healthy Campus Initiative. He has also served the campus as Interim Vice Provost for Graduate Education and Dean of the Graduate Division. Dr. Goldstein is also a Faculty Associate of the Center, I'm proud to say. At UCLA, he teaches graduate courses on complementary and alternative medicine, self-help, and self-care. He is the author of 2 books, The Health Movement, Promoting Fitness in America, which was published by Macmillan, and Alternative Healthcare, Medicine, Miracle, or Mirage, published by Temple University Press. His presentation today is entitled, Meeting the Nation's Primary Care Needs. Please join me in welcoming Dr. Goldstein.
Thank you, Jerry. Thank you all for being here. It's great to be here back at the center.
I took your water.
You took
mistake.
my water. I want to retract everything I just said about being here. But now that I have my water back, all is good. We have a limited amount of time. What I'd like to do today is go through the presentation that you have in front of you, and then do it concisely enough that there's some time left over for discussion. And you can see what we're talking about is meeting the nation's primary care needs and what the possible roles might be for groups of licensed healthcare providers that are usually considered alternative or complementary providers. And we're talking today about 4 distinct provider groups, doctors of chiropractic, doctors of naturopathic medicine, and practitioners of acupuncture and Oriental medicine, as well as direct entry midwives. And you can see that this the presentation is from myself and a gentleman named John Weeks, who unfortunately couldn't be here today, who represents the Academic Consortium for Complementary and Alternative Medicine, or ACAC. Let me just say a few words about ACAC because many of you may not be familiar with the organization. ACAC is a consortium that brings together accredited schools that train what we might call complementary or alternative health providers. So it is a grouping of schools of educators in these fields. And this project that I'm talking about today is a project that was done in full collaboration with ACAC. And I'm going to talk a little bit about the project and then very, very briefly talk about a couple of very basic issues in primary care that many of you, I'm sure, are already quite conversant with. Then I will spend some time talking about the findings from this study, and then conclude with the recommendations that John Weeks and I draw out of the study. Let me begin by specifying again that we're talking here today about 4 different professions: practitioners of acupuncture and Oriental medicine, doctors of chiropractic, direct entry midwives, in other words, midwives who are not nurses, but who just directly enter that profession as midwives, and then doctors of naturopathic medicine. As you can see on the slide there are certain characteristics that each of these groups have in common. First of all, each of them has their own national accrediting group, and you can see the year that that accrediting agency was established. And quite importantly, each of them has already been recognized by the U.S. Department of Education. Okay, and you can see that the time lapse, but all of them have that recognition sometime after their national accrediting agency was established. What gets accredited are schools and programs, and you can see as well that they vary considerably in number. There are 54 different programs that are accredited to provide instruction in acupuncture, only 16 chiropractic colleges, 12 direct entry midwife programs, and 7 naturopathic medical schools that are accredited. Each of these groups also already has a national exam. And then it gets a little more complicated because, as you know, regulation of health providers in the United States is not national, but is state-based. And these groups vary in terms of the recognition they have in terms of the numbers of states. Chiropractors are the only ones who are recognized in all 50 states, and then the numbers drop off. Acupuncture, 44 states, direct entry midwifery, 22, and only 16 for doctors of naturopathic medicine. So when we're talking about the licensed practitioners and this sort of group we're talking about here today, we're roughly talking about a little over 100,000 individuals in the United States, most of whom are chiropractors. Okay. Now, let me describe a little bit the project on which the findings that I'm going to be describing are based. ACAC, not surprisingly, the deans and other people who meet at ACAC are very concerned and aware of the situation in the country in terms of primary care, and concerned about the role that their different disciplines might play in the future in terms of primary care. And the board of ACAC came together and decided to create this project to systematically look into how some of the different professions that make up ACAC felt about their future as professions in terms of primary care and becoming primary care providers. And what you see on the slide in front of you there is a listing of those of the professional groups that represent the 4 professions that I was describing earlier. The Council of Colleges of Acupuncture and Oriental Medicine, the Association of Chiropractic Colleges, the Midwifery Education Council, and the Association of Accredited Naturopathic Medical Colleges. So those were the 4 groups that were involved in this particular study that I'm speaking about today. There are other groups of other types of complementary and alternative providers that are members of ACAC that we're not concerned about here. Okay, so but it's these 4 groups that we're focusing on, and they're the only ones that participated in what I'm going to be talking about today. Okay, so ACAC came together, and as you can see, I won't take a lot of time to go through the details of this slide, but the ACAC board and the executive board discussed the project that I'm going to be describing. They agreed, in essence, that it was a good idea, that John and I were reasonable people to carry it out, and they sort of gave it their blessing and got the 4 groups that I just described previously involved. And what did they get involved to do? Well, what they got involved to do was each group on their own was going to write a chapter about how they felt their profession related to primary care currently in the United States and how they might relate over the coming decades. And the goal was not to create a consensus among these 4 professions, but to have just one location where each of them could set out what they as a profession felt about primary care and the future of their own profession in terms of primary care. And what we asked them to do was to write that chapter not in just any way that they wanted, but to follow a preset template that we had come up with that asked 15 very specific questions. So they had to respond to those 15 very specific questions or areas, and they had to use a definition of primary care that was a mainstream definition of primary care. They couldn't use a definition of primary care that was just what you might call a local definition of primary care, one that they came up with themselves. And they were to write these chapters. Then they were to get the endorsement of the material they had written by their larger organizations that they represented. Then those 4 chapters came together. There's one on chiropractic, one on direct entry midwifery, etc. And John and I wrote an introductory chapter and a concluding chapter that has to do with health policy. And we've been trying to promote it by giving seminars in places like this. And also now it's the entire work is going to be published in a refereed journal, Global Advances in Health and Medicine. So that sort of in a very brief way, brings you up to date on what the process was and what this project is all about. Let me move on from that to talk very, very briefly about primary care and just make some very global types of statements. And again, I'm sure that most of you here and those of you who are listening in on the webinar are already quite familiar with the points I want to make, but I think we need that background to start off with. So the broader context of primary care. The first thing that, and the most striking thing is, of course, the emphasis on the shortage of providers of primary care. So for example, HHS says now that there are currently a need for 17,000 more primary care physicians in the United States today, and they estimate that need to grow to 46,000 by 2025. And 2025, when I think of things, I think, gee, we must be on the verge of the year 2000, right? But it's not really that way. This is already 2013, right? 2025 is 10 minutes from now, okay? So there's a big gap, and that gap is getting larger. So number one, shortage of providers. Number two, all the different groups, Institute of Medicine, Robert Wood Johnson, all the different national health policy groups that have considered this question have all concluded, at least to some degree, that the solution must reside then in an expanded role for non-physicians in terms of primary care. There aren't enough primary care physicians now. There will be even fewer in the future. The Affordable Care Act, bringing more and more people into the healthcare system, is only going to increase the demands for primary care. Clearly, if there's going to be a solution to this, it's going to involve non-physicians taking on an expanded role. In addition, and this is again something to mention at the outset, there is no standard accepted definition of primary care. Right? Each of the groups that looks into this, Institute of Medicine, Robert Wood Johnson, they have their own definitions. Of course, there's overlap between those definitions, but there are differences in those definitions. And then, not surprisingly, the different professional groups that look into it come up with their own definitions of primary care. So here we have consensus that there's a tremendous need for primary care providers, but no definition of what a primary care provider is, or what are the skills that are entailed in being a primary care provider. So it's at best a messy sort of situation. One of the things that is clear, let's say if we look at the IOM report on the future of nursing, there was a very strong statement there that advanced practice nurses, nurse practitioners, to endorse them as independent practitioners and leaders in primary care. As you may know, just last week, I think Kaiser put out a piece that was jointly authored with the Philadelphia Inquirer, I believe, about all the resistance that is coming from the medical profession about accepting those recommendations for advanced practice nurses being independent primary care providers. So on the one hand, you have all this policy emphasis on expanding the notion of who a primary care provider is going to be, but it's not a solution that is accepted by the powers that be. There's a tremendous amount of resistance to this, and resistance coming, not surprisingly, from physicians. So you see there on the slide, it talks about, is there a new era of pluralism in primary care? But there's a question mark there. There may be a new era of pluralism, but it's not going to be a simple, smooth transition, okay? Some other things just to mention about trends in primary care. There's also been an increased emphasis both in terms of medical education and all sorts of things on what gets called patient-centered care. Well, if there's no definition of primary care, you shouldn't be surprised to hear there's really no definition of patient-centered care. It's another thing that everybody agrees that it's good, everybody wants it, but nobody can really say what it is. For our purposes here, though, we can say that it probably will mean there will be a dovetailing of that emphasis on patient-centered care with this notion of pluralism in primary care. Because to the extent that things become patient-centered, some of those patients may want to interact with different types of providers, and they may want to interact with them as their primary care provider. There's also a whole host of other issues that, again, dovetail with this notion of increasing the pluralistic quality of primary care providers. One of them is some of the provisions of the Affordable Care Act itself, and I'll talk about that later in the presentation, that emphasize the use of expanded teams for primary care. Then, of course, there are all sorts of other groups. One is mentioned here in the slide, the Institute for Alternative Futures, that have talked about primary care scenarios, and all of them, again, emphasize an increased role for non-physician providers, many of them because they see an increased role for things like the computer and direct access of patients. And patients may not want to go through traditional providers. They may want to go right to a chiropractor, right to a midwife, whatever. And then, of course, the last thing there, but I guess it should be the first thing, is cost. It's always the elephant in the room. There is a notion that healthcare costs money, and that it costs a lot of money, and it should cost less money. And generally, not always, but generally, these non-physician providers cost less money than the physician providers do. So there's a whole bunch of trends, a whole bunch of things happening that would seem to be adding fuel to the fire, if you will, to increase the amount of pluralism that we might see in terms of primary care and the provision of primary care services in the United States. So what we really are talking about here, primary care, is there going to be a new role for these licensed integrative health disciplines that were described earlier on, these 4 professional groups that we're talking about today. So that's what this ACAC project is all about. Okay, so now the next few slides, and what I'll be talking about for the next, I don't know, 10 or 12 minutes, is really a summary of what these 4 papers talk about. Okay, to go into each of them in tremendous detail would be impossible. We don't have the time for that here. But just want to summarize some of the major findings. The first one is, if you look at these 4 papers, one thing they all have in common is that these professions already define themselves as being primary care providers. Okay. And there are quotes there from the midwives, from the naturopathic doctors, etc., but they just give you the flavor of it. So all of the chapters, and they were each created independently, sort of starts off on the same note, where the people are saying, look, this is not an issue for us whether we're going to be primary care providers. We are primary care providers. That's how we think about ourselves, number one. Number two, they go on to say, it's not just us thinking about ourselves. If you look at the Department of Education accreditation standards that's already the legal standards of the country, they already accept us and describe us as primary care providers. So in one sense, the chapters all begin with what you might say is a conflictual kind of tone, like, wait a second, we're already there. We don't have to prove ourselves. We've already proved ourselves, and the nation already accepts us. Why do we have to prove ourselves again? Well, why do they have to prove themselves again? Well, that's the bottom point on the slide there, because they have problems getting direct access to patients. Okay, so all of them emphasize that in the real world, they already have a primary care relationship with not all, but with many of their patients. So they either talk about it as a first choice. All of them made the point, there are people out there who see our profession as their first choice. That's who they want to engage with first. Some of them talk about first entrance, first contact, first access, portal of entry. All these terms vary, but they all come down to the same thing. Each of these groups stressing, we're already first for some people, okay? And the underlying issue there is, if the legal situation would change, if the insurance situation would change, we would be the first choice for many, many more people, okay? So that's the attitude that all of these groups take. And I think we can see that there's a truth to that. There's no question about it. Right here in this room, I'm sure everybody knows many people, if not the people yourself sitting here in the room, who already think of conventional medicine as alternative medicine. And what I mean by that is, when you have a healthcare problem, you might go to a physician, but only after you've gone to your naturopathic doctor and after you've gone to your chiropractor, whatever. So people don't reject conventional medicine, but things have sort of really switched around for some elements of the population. So when we look at these papers, this is one of the strong messages that comes across. Hey, we're already there. We're already doing this, not for everybody, but for many people, okay? So a present fact of life in the U.S. healthcare system is that these professions are already serving as primary providers of care for significant groups of citizens. Not everybody, but for real groups of people who are out there. Okay, again, from the papers, the next thing that emerges is, as I mentioned before, they say, look, we already have this formal recognition as primary care providers, and that's significant and it's important, but it's very limited recognition. So that's the second point that the papers all agree on. And it's a limited recognition. They emphasize the extent to which A, it exists, excuse me, and B, to which it is growing, but even with that growth, it is still quite limited. So they point out, for example, that in the scope of practice legislation in some states, these providers are already explicitly called primary care providers. And as you can see there on the slide, for the acupuncturists, it's 3 states. For the chiropractors, it's 2. For the naturopathic physicians, it's 8 states. For the midwives, it's almost everywhere, although that is for maternity care, not for general and expanded concept of women's health. And that's what we're talking about here today, maternity care, not an expanded concept of women's health. So we see there's already been some movement there in the scope of practice legislation on a state-by-state basis, and all the papers call attention to that. And similarly, there have already been a few instances where states have included one or more of these professions in statewide programs to deliver primary care, primarily in underserved or rural areas where you don't have, where the physicians are even less available, and in primary care medical home situations where you have certain state legislation fostering that concept. So again, one of the things that comes out in the papers is, so you have this identity issue, the fact that some people already recognize them, and there's been some legal acceptance in terms of some states and an increasing amount of legal acceptance for these professionals as primary care providers. So that, you might say, that's sort of the good news that comes out, or that's the positive message that comes out of these papers. But when you look at the papers, they also talk about some challenges. One of the challenges is that each of the professions acknowledges, or at least 3 of the 4 professions, I should say, acknowledge that not everybody in these professions wants to be a primary care provider. As a matter of fact, many of the people in these professions don't want to be primary care providers, and they don't want to have much to do with primary care. And therefore, the profession itself is going to have to figure out some way to resolve these issues internally. So if you take a group like chiropractors, they're really very, very split on this. The image that, all chiropractors want to be primary care providers is just totally untrue. Some do, and some are very, very strongly opposed to it. So there are tremendous issues within each of these professions about this, with one exception, and that is naturopathic doctors. There is a consensus, a desirability to be seen, that the profession should be seen as capable of providing primary care. Then there are some people in the professions who, and the people in the professions who are against being primary care providers are against it for a number of different reasons that are illustrated there in the slide. Some of them are really, they're not interested from a conceptual basis. They don't think that's what their profession is about. Okay, some of them are not interested in just terms of very practical issues of what it would mean for them to become primary care providers. So there's a range of reasons why they're not interested, but each of the professions, or 3 of the 4 professions, have pretty major internal issues to deal with. Okay, so that's one of the challenges that comes out. Another thing that comes out is a recognition that to some degree, all of these groups lack certain skill sets and abilities to take on being primary care providers in the American context. And that if they are to become primary providers, they are going to have to figure out some way to get that training, get that education, and make it known that they can do those things properly. And that's not so easy. It's not so easy for an existing profession to, first of all, to admit that they don't know something. Very, very hard. people in the social sciences probably don't understand that, but anyway, take my word for it. It's difficult for a profession to admit that. And then, of course, it's very different in terms of the real world of the professions to get people to say, well, you don't know this, so you're going to have to be retrained and you're going to have to be tested. Well, who's going to test me? I've been in practice for 20 years and no one's going to test me. Very, very difficult. Okay, so the professions are dealing with these kinds of issues, and each of them, as you can see there on the slide, specifies a different set of the skills or abilities that they are missing, but to some degree they all acknowledge that there are things that they are missing and they'd have to be brought up to speed on. So, and then there are a whole bunch of other challenges that I think will not be a surprise to anyone in this room. Clearly, 3 of the 4 groups have licensing issues. Only 1, chiropractors, are licensed in all 50 states. So for each of the other 3 groups, they want to be licensed in all 50 states. That's an issue. Scope of practice legislation, very important to these groups because state by state it varies. So scope of practice is very, very uneven. And they're looking for some way to smooth those issues out. Reimbursement issues, those are really crucial. And these things are all linked up because, and when you read that, I'm going through this very, very fast, not giving it the depth and nuance that you would get when you read the chapters. But for example, let's talk about reimbursement. Each of these, or many of the groups, talk about the fact that there are insurance providers who say to them, in essence, we would like to be able to reimburse you for X, but we can't because the scope of practice legislation doesn't allow that. Well, how do you change? So all these things, all these areas are intertwined. You can't change one without starting to change the other. And so a lot of them come down to legal issues, lobbying issues, the entire area becomes very politicized very, very rapidly. And it won't be a surprise to you to realize that these groups, these professions are acutely aware of whatever subtleties or not so subtle issues are involved here, particularly on a national level. But each of them points to examples of where they have been able to work around these issues to their great success. For example, there are at least 2 states now where HMOs offer people the option of having a chiropractor as their primary care provider. And in Illinois, for example, where this has been done, they have report very high levels of satisfaction for the small number of HMOs that are doing this, and also greatly reduced costs for those people covered who choose. No one is forced to do it, but those people who choose to have chiropractors as their primary care provider. The main reason the costs are down is because those people get hospitalized, many, many fewer hospital admissions. So each of the groups points out to places, the few places, small programs with these kinds of things are starting to change. And then each of the papers talks about what they think the next step should be to move the process along. One of the things that they agree on is the need, and this would be certainly relevant for the people in this room, to get health services data that policymakers need so that policymakers can make more informed decisions about the kinds of issues we're talking about here. There's also an understanding that definitions of primary care and patient-centered medical homes and all of these things are emerging in team-based medicine, and these professions are going to have to be much more proactive in specifying how they might fit in with these changing definitions. Another thing that many of them agree on is distinguishing between primary health care and primary medical care. They feel a lot more competent, a lot more qualified in terms of being able to deliver primary health care as opposed to primary medical care. But of course, that's a definitional issue itself, and we probably have a lot of disagreement on how to define those two terms. Okay. I wanted to focus before going on to talk about the recommendations that John Weeks and I make coming out of all this. I wanted to focus on one other thing that comes out of these papers that I thought was particularly important, especially for the people here at the center, which is there's an acknowledgement in a number of the papers that the Affordable Care Act holds the potential for bringing about some change in this arena. And the main reason for that is the notions of primary care. I remember when I began, I talked about there's no standard definition of primary care. But in the Affordable Care Act, there is this notion of core components of primary care, which is in terms of patient-centered medical homes. So the act isn't setting out to define, to come up with a definition of primary care, but because it is concerned with patient-centered medical homes, it then has to set out, well, what are the core components of the care that would be delivered in these homes? So sort of in a backdoor way, the Affordable Care Act starts to set out some standards for what we might in the future expect from primary care providers. And up there on the slide, you can see that there are 6 things that are mentioned. And they're an interesting group to look at. Enhance access and continuity of care, identify and manage patient populations, plan and manage care, provide self-care and community support, track and coordinate care, measure and improve performance. They're interesting in a number of ways. And it's a sort of a plus-minus thing in terms of the issues that we're talking about here. Looking at this list gives a lot of these professions a lot of hope, because none of the things on the list are things that are really associated with being a physician, okay? So whereas the battle, and let's say if you think of what's going on between advanced practice nurses and physicians right now in primary care, a lot of it comes down to, oh, do you have this clinical skill? Do you have that clinical skill? All that gets wiped off the table if this is the list that's going to define primary care. None of it is very clinical at all. So in a sense, that's an opening for all kinds of other groups to get involved in primary care if these are the things that define primary care. So that's the positive that these professions see. On the other hand, there's the negative that these professions see. Keep in mind that ACAC and the groups that come together, these are schools. These are chiropractic colleges, Association of Chiropractic Colleges, so the Association of the Naturopathic Medical Schools. The negative that they see is they say, wait a second, we're not really teaching our people these things either, okay? So on the one hand, this opens up tremendous potential for them and they see that. On the other hand, they say, gee, if we're gonna actualize that potential, we're gonna have to really revise everything that not everything, but many of the things that we're doing as well. So there's a really an approach avoidance kind of thing here. And it's very interesting if you come to this issue the way I do, which is really emerges from an interest in the development of the healthcare professions and trying to understand how professions change over time, that you have professions that understand that the landscape is shifting, that their future will depend on being able to adapt to that shifting landscape. They start to see this landscape shifting. It's like the earthquake is beginning. When they read this, they say, there it is, okay? And on the one hand, this is what they're waiting for. On the other hand, it scares them to death, right? Because they have to let go of what they've been doing as well. So this kind of what you might call ambivalence comes through when you read these 4 papers carefully, okay? So, and this is the point I was just making, as we think about this, the issue of primary care in the future may be less having to do with traditional physician-based primary care skills, as opposed to those other things. And then what does that mean for people who are involved in education of healthcare providers? Of course, here we're talking about these alternative professions, but if I was giving this presentation in another context, you could use it to talk about standards for primary care physicians as well. They're going to be equally affected by this kind of thing. Okay, so let me jump then, because I want to make sure we have some time for discussion, to just talk about very briefly the recommendations that John and I come up with at the end of this whole deal. We have 2 sets of recommendations. One is to those 4 disciplines themselves. The first recommendation is to clarify the relationship, to specify exactly what they can and can't do. There's been a tendency of these professions to avoid that kind of issue, right? But if things are really going to change, they're really going to have to specify, let's say if you are a certified or licensed as an acupuncturist, what can you do? What can't you do? What training will you need to bring you up to speed for the things you can't do? And how you're going to be tested to see whether you can really do those things. This scares the hell out of these professions, okay? Not so much because the leaders don't see it, they do see it. It scares them because they have to go back to the membership of their professions and say, if you want something that you've been saying you want, you're going to have to change your ways and you're going to have to do something differently. And that's just a very, very difficult issue. So, but we want to be, John and I want to be very clear to these groups that if you're going to advance in this, they really have to specify what it is, the competencies that they have to develop and how they're going to be educated and tested to competency. So that's the first thing we recommend to them. The second is that each of these groups has to really clarify their primary care specialist distinctions that they have, that they've avoided doing up to now. And each of them also has to get much more specific about a model of primary care. Remember when we began, I said that each of these groups identifies already as providers of primary care. And they say, we deliver primary care and we deliver it better than physicians do. But it's very vague. They never really get very specific about what they mean by that. So if you want to make that claim, fine, make that claim, but get specific so it can be a testable claim. So those are the things we recommend to the disciplines. And then to workforce planners, policymakers, people like yourselves, obviously the first thing you always recommend is more research, right? That's what keeps you in business. So what about doing some serious healthcare and epidemiologic research on those patients who already choose these providers as their first choice for primary care? We know almost nothing about these people in the real back and forth of care delivery. Now is the time to include them in serious research done by objective institutions and develop that knowledge base. And also do some research on those few places where these professionals are already involved in the delivery of primary care, these pilot programs that I mentioned earlier. So those are the recommendations we make there. And we conclude by saying, in essence, if there is a will, there could be a better way to utilize these professions to help meet the nation's primary care needs. And now is the time to start thinking about it. So I rushed through, but I wanted to make sure we had time to talk. So please, your questions and comments are welcome. You mean I rush for nothing?
Yeah. Based on the standards for primary care provider, to me, they look like a more the profession like a health educator, nurse practitioner, or we call navigators or case managers. So is that the direction they are pushing for? Or, to sort of create these professions are in existence already, but they are not really declared as independent profession, not like doctor specialist.
Well,
Michael, could you just summarize the question?
I'm sorry.
Before you answer, because I don't think the mic is.
Okay. Yeah. Let me see if this is a fair summary. So when you look at those list of the criteria for primary care, it doesn't look to you like a traditional primary care provider. It looks like something else. And you mentioned a whole group of workers, health workers, starting with health educators and going on. And you started off very specific and strong, but you sort of concluded with less clear what the question was. So the question is this the way it's going?
Right.
I think that's what it comes down to. Well, I think to a large degree the answer is yes. And why is it going this way, which isn't the way any of these specific groups, including physicians, want it to go? It's going this way because the nature of healthcare in the country is shifting. And so what we think about as primary care is going to shift as well. You can start at any particular point you would like. But one way that you might want to think about it is in terms of a particular healthcare problem that you or a friend or a family member has, and how that problem is dealt with today as opposed to 35 years ago. And you see right away that when people have symptoms, they go to the internet, and that leads them in certain directions. And they do all sorts of things such that when they get to their primary care provider, it's in a different state than they were before. And what is that primary care provider to do then? A lot of it comes down to those things: coordinate the care, and all the things that were on that list. So I guess the basic message is that if it's true that the structure of healthcare is changing in this country, really this definition of primary care is going to change along with it. And it's the definition of primary care is probably, this is me speaking now, probably going to change in ways that makes it more amenable for these other groups to really participate as something called, quote, primary care providers. Okay? A lot of it is going to be moving people around and asking people questions in front of a computer screen and deciding on the basis of the algorithms, you go there, he goes there, he goes there. That you may not like that, right? But that's the way it is moving, okay? And that is going to make it possible for many different points of entry that we might call primary care into the system, okay? I know that people don't like to think about it this way, but you can think about it as sort of what happened to travel agents with the internet. There's still travel agents, okay? But most people don't use them most of the time. Most people, primary care travel agentry is done yourself. And then there are certain situations where people have a lot of money, turn it over to their travel agent, right? Or people in very special situations or at a special moment, you go only so far and then you really need that travel agent. And there's a button you push and you can talk to the travel agent, right? It sounds terrible to be talking about primary health care in those terms, but that's the way it is shifting, not so much on an individual basis, but within the institutions that provide this care. Yeah.
Question about mental health care providers and where do they align in terms of the alternative versus traditional perspective on giving care? Because you do have mental health specialists who are physicians, psychiatrists, you also have therapists, you have psychologists, you have social workers. I'm just curious in your research.
Well, of course, the question is where do mental health practitioners fit into this? They were not a part, obviously, of the project that we're doing here. So anything I would say is really just my impressions and speculative. In the case of psychiatry, you have a profession that has been running away from primary care as fast as it can for the last few decades as a way of establishing itself within medicine as real doctors. So the last way they're going is towards primary care. You have psychologists, a very, very large group of people that in some ways in California, for example, it is still possible. You have some psychologists who have prescribing rights in California, for example. Or at least you did up until a couple of years ago. I'm not sure on the situation today. So there is some widening. There's a lot of widening of certain mental health professions, but I don't see them as fitting into this. They're not going to be a part of this, okay? The way I would look at it is the other way around, that whatever definition of primary care you choose, it does usually have a very strong element of mental health in there. Then the question would be, what kinds of people are best able to sort of do that kind of work? Then you get into kinds of empirical kinds of questions. So for example, there's a tremendous agreement that in this country we overprescribe antidepressants at a very, very high rate. Almost all of that overprescription is by family practice, primary care physicians. So that would be one indication, if we're looking at that as an outcome, that, gee, maybe these people don't do that so well. Maybe we should be prescribing less of it, and maybe we should be doing other things. The case could be made that some of these groups, let's say like naturopathic physicians, could do a much, much better job. So it gets very, I don't have an answer for you to your question in terms of the project here. So I don't know is the answer.
I do have a question, like based on somebody's symptoms, would they choose like one of these alternative practices for like a certain purpose? Like why would you, like if I like don't feel well, like which one of these people would I go to? Like a chiropractor and like an alternative medicine person, or how do you like choose your person in this alternative medicine system?
The way it happened, the question is, how do people actually, for those people who make a choice for these practitioners as their provider, how does that choice come about? There is limited research on this, and the limited research, and I'm going to sort of summarize it and oversimplify it. But what I would say it comes down to is this: for most people, not all, but for most people, they have a particular problem. They don't start off by going to alternative providers. Traditionally, they start off by going to conventional providers. For a variety of reasons, they're not satisfied with the outcome of that interaction, okay? And they are led to an alternative provider where they have a better response, whatever that means, whether it's psychological, physical, whatever. Then, for some of them, and only a portion of them, that response in essence gets generalized, particularly if the alternative provider they go to has a theory, an encompassing theory of illness. So the best example there would be things like acupuncture and Oriental medicine. People first go because other things aren't working. Some people don't have any benefit. Forget about it. Some people do have a benefit. They may have a great benefit. And in addition, they may come to feel, they may learn about a different approach to health through having that interaction, so that when they have a subsequent problem, even if it's somewhat different than the first problem, they now think, I might ask so-and-so about this, or maybe they have something to say about it. And over time, they start to change where they seek their care initially. I think that's the way it happens, at least if we look at the limited empirical research that's available. Now, that would be very different than a system where you, let's say, are a member of some HMO where you have a choice of all these kinds of things. We don't have any really empirical evidence on that. No one knows what would happen there.
So, Michael, I have a question. It's sort of implicit, I think, in one of your slides near the end about recommendations to the disciplines themselves.
Yes.
But let me be a little bit more explicit. It seems to me one of the distinctions between these professions today and, say, primary care physicians is that primary care physicians are held to a certain legal standard and legal liability that may not currently be true for these alternative primary care practitioners. And so I wonder if you could give me a sense of whether the professions are willing to take on the risk of not only providing primary care and being sort of the point of contact with patients, but also exposing themselves to the liability associated with, let's say, they miss a diagnosis and now they're being sued by a patient who said, well, look, I had cancer and you were treating me for something else, and I'm now going to sue you for missing the conventional approach to my problem.
Okay. Okay. So the question has to do with legal liability and malpractice and where this fits into it. Let me give you a two-pronged answer, and I'm not an authority on this, so it's based on my limited knowledge. First of all, alternative providers who are licensed, they deal with malpractice situations all the time, to the extent that they are treating things within their scope of practice, okay? And chiropractors are certainly sued, and naturopathic so the people in the field, they're somewhat familiar with this. I think, though, the more important answer in terms of the issues you raised and what might happen in the future has to do with things like patient-centered medical homes, where these individuals be practicing in a larger team context, and where things like medical liability would be spread around, where there are checks and balances built into the system. But the answer the answer is partially in terms of the setting of practice, number one, but also all of these groups are concerned with expanding their scope of practice. They are willing, in essence, to be sued. They wouldn't put it this way, but they're willing to be sued for these things if they have the legal right to make determinations about them, okay? And so I think this is an area that absolutely is going to change. And basically, what we're talking about for these groups, and this is really the underlying issue from let's say, a medical sociology type perspective here. When you have groups that are on the margin, as these groups are, the tendency is always to talk about the disadvantages to the group for being on the margin. And those disadvantages are real, right? They don't get reimbursement and all this kinds of stuff. But once they're established, they also have certain advantages, okay? And that's what you are pointing to, which is they have a freedom and a license, not a legal license, but a license in the general use of that term, to do all kinds of things that other people might not do if they choose to do. By moving into what we've been calling here this area of primary care, they will be moving away from the margin into the mainstream, and they will have to relinquish that type of freedom to a large degree, okay? That's what the battle is about within these professions. In essence, the professions already have people who they serve as primary care providers, and they do whatever they want with them, okay? If they were to become primary care providers, let's say within the UCLA healthcare system, or within Kaiser or whatever, they would have much less latitude to do what they want, okay? That is the essence of, of what is going on. So on the one hand, these professions see this as an opportunity to become less marginal, to increase their economic standing, to increase their status, to increase their power in certain realms. You gave the example of being able to diagnose certain things and refer, and some people want that, and others within the profession want to keep things the way they are. Okay, now this, if we look historically, has always an issue within conventional medicine. It has nothing to do with chiropractors or naturopaths or anything. It's every professional group deals with these things as they get status in the society, licensure, scope of practice expands, as they get certain rights and certain prerogatives to do things, they have to give up other kinds of latitudes and other types of freedom that they have. And that's really at the broadest level what we're talking about here. And that's why from a sociological point of view, the whole thing is so fascinating. And if you're not comfortable talking about it in terms of groups like chiropractors, let's say for the people in this room, just think about it in terms of nurse practitioners, right? Forget chiropractors, forget naturopaths if you're not comfortable, acupuncturists if you're not comfortable with them. It's the same thing with nurse practitioners and physicians. It's the same issues. The nurse practitioners, it's not over the clinical skills anymore. No one's arguing about the clinical skills. That issue is like a 10-year-old issue. The issue is simply independent practice. Some of them want to be independent practice, like they want to have an office in this building and just be an independent practitioner, but most of them don't want that. They want to be, quote, independent practitioners within some larger organization and treated the same way that the doctors are treated within that organization. So it's the same exact thing of what they're willing to give up and what they want to get and how they balance those issues. That's what it's really all about. Yeah.
A question relating to a potential emerging role of schools of public health, but first a bit of personal background. My formal training included health economics, medicine, and public health. My first job was as a locum in a poor area of Wisconsin. And I was to work with another man. After a week, he said, look, I'm going fishing, you do it. Here I was, primary care doctor. What saved me? The nurses, and we had a chiropractor in the area, and I checked up. He went to an excellent school. I got to know him, and we were referring to each other. Now, this was for pragmatic reasons. The people liked him. I wasn't going to get anywhere trying to undermine him. No, my most useful training came through public health and some of the special projects I did while a public health student. So, to change, I'm thinking I went to a very good medical school. I think it's going to be damn tough to get the various schools to change their curriculum and to come to some sort of common ground. I think it would be far easier, maybe, and this is my question, to have schools of public health add some of this background material and either make it a requirement for other professionals. Now, whether it's an MPH or we have 6 months or something, I'm throwing this tough question.
No, I think you raised an excellent point. It's probably a good thing to end on,
Yes.
given the time constraints that we have. But if you go back to that list of the criteria for the patient-centered medical homes, and you think, where would anybody, whether it was an acupuncturist or a physician, learn about these things? It's going to be in a school of public health.
Okay.
There are tremendous opportunities there. Interestingly enough, the resistance doesn't come from the leadership. I can tell you just here in California, or here in Southern California, where we have a number of schools of acupuncture and Oriental medicine, the leadership of those schools for the last decade has been very desirous of forming linkages with schools of public health over just these issues. They called the words, the specifics of the words were different, but the issues were the same. Where did the negativity come from? It didn't come from the schools of public health. It came from the students who were coming into those programs who say, wait a second, I want to be an acupuncturist. What does this have to do with acupuncture? I'm going to go to that other school down the block that doesn't require this. So it really comes down to convincing the practitioners, to making them understand what their futures are going to be, which is exactly the same issue as it is in medical school. When people, they have their reasons why people come into medical school, and the professors or the administrators saying, well, medicine is changing, we got to go this way and this way. That's not what I'm here for, right? So it encapsulates this thing, but I agree, and I think this is a great point to end on, that the schools of public health potentially have a very, very strong role to play in terms of bringing this about. So,
Excellent.
thank you very much.
Michael, thank you. Thank you very much. Thank you. Thank you for attending in person, and thank all of you who attended today via webinar. Our next seminar webinar will be on Tuesday, October 9th. I will be the speaker, and I will be talking about the implementation of the ACA, the Affordable Care Act, in California. Thank you again for attending, and I look forward to seeing you all later in next month. Thank you.